Good day, everyone, and welcome to our discussion on cervical cerclage in combination with other treatments for preventing spontaneous preterm birth in singleton pregnancies. Our group is Group C4. So let's begin with a basic introduction to this topic. So what is cerclage? Cerclage is a preventative treatment that's aimed at reducing the risk of preterm birth by reinforcing the cervix, which may be weakened or incompetent. This procedure involves placing a stitch around the cervix to support it and help it remain closed until the fetus reaches a more viable stage for delivery. The decision to use cerclage often depends on the patient's medical history and the specific risk factors associated with preterm birth. So if we look at a bit of a background to this, we have cervical insufficiency or an incompetent cervix. This is a condition where the cervix begins to dilate and efface prematurely without contractions. This can lead to preterm birth and often requires intervention to prolong the pregnancy. Factors contributing to cervical insufficiency include previous cervical trauma, congenital abnormalities, or previous surgeries. The cerclage procedure. So if we look at the types of cerclage, we have cervical cerclage, like the MacDonald and Shirodka methods, as well as the transabdominal cerclage. The MacDonald method involves placing a simple stitch around the cervix. The Shirodka method uses a more complex approach, with sutures placed at deeper layers of the cervix. The indications for this: it's typically recommended for women with a history of spontaneous preterm birth and cervical insufficiency, identified through ultrasound or clinical examination. It may also be considered for women with a short cervix identified during the pregnancy. The timing. The cerclage is usually done within 14 to 16 weeks of gestation, depending on individual risk factors and clinical judgment. It may be removed around 37 weeks of gestation or earlier if labor begins or complications arise. Next, we'll look at the methodology. The review was aimed at determining the efficacy of using combined therapy to prevent preterm or spontaneous birth in high-risk patients, as opposed to the single use of a cervical cerclage. Participants only included those patients with singleton pregnancies in their second trimester and administered combined therapy due to being high risk, so a cervical length of less than 25 millimeters. The procedure and preparation. The study randomized the groups into the intervention and control group, so those receiving only a cervical cerclage. All the intervention groups were given combined therapy such as a cervical cerclage with progesterone or pessary, etc., and they were compared to the control group. Variables measured. These were divided into independent, so patients have cerclage or they don't have cerclage, and dependent, so primary and secondary outcomes. These outcomes measured included neonatal morbidity, survival, miscarriage, the need for tocolytics, and/or caesarean section. The method of analysis. The search strategy used for the review was adopted from Cochrane Library, clinicaltrial.gov, and ICTRP. Data collection and articles. The data collected was done via electronic bibliography and articles reviewed from 2017 to 2024. Search terms included preterm labor, cervical cerclage, second trimester, pregnancy loss or cervical insufficiency, and the Boolean operator AND. The meta-analysis of the data was adopted via Confidence, RevMan 5.3 software, and R along with its libraries. Next, we will look at the results. The article outlines the effectiveness of the cervical stitch to prevent preterm birth in women with high-risk pregnancies. High-risk pregnancies include previous preterm birth or pregnancy loss, or a short cervix. Evidence has found that the cerclage may reduce the risk of perinatal death, as opposed to no cerclage. However, this evidence is not entirely substantiated. Having a cerclage reduces preterm births before 37, 34, and 28 weeks of gestation. When referring to cerclage use in neonatal morbidity, there was no major difference between mothers that received cerclage and those who did not. The same applies when referring to a healthy baby discharge. In conclusion, this literature suggests that receiving a cerclage is beneficial to reduce preterm birth in high-risk pregnancies, but determining its benefits in perinatal outcomes still requires further investigation. When it comes to the forest plot and meta-analysis thereof, we can see that there is an overall risk ratio of 0.82, with a confidence interval of 95%. We can also see, based on the forest plot, that the forest plot favours cerclage over the use of no cerclage. Thus, it can be said that there is an 18% reduction in the risk in preterm births with the implementation of a cerclage as compared to no cerclage. Finally, we can conclude with these final comments. In conclusion, from the articles reviewed, it can be concluded that whilst utilizing cerclage in combination with other treatments for preventing preterm birth in singleton pregnancies may be beneficial, in some cases, there is presently not enough data to definitively support this claim. However, the utilization of a cervical stitch, cerclage, versus no cerclage does result in a significant reduction in the risk of preterm birth, especially in high-risk pregnancies. However, the benefits of cerclage in the perinatal period remains unclear and requires further investigation. Thank you for your attention.